years. But what I would like to see in 5 years' time, most of our nurses to become the simulation educators and integrate simulation in India and also from other countries. So please keep writing in the chat box your vision in 5 years' time for simulation and where you're from. All right, we'll wait for 1 more minute before we start. So keep them coming. Excellent. So Smita, from how many countries we have today participants? Please put your videos on. It will be great to see you all. During the pandemic,
Dr. Geethanjali. I think she has some internet issues.
Yes.
This is Ella Scott from Australia. Main speaker.
I'm so sorry, power disruption again. Okay, all right. So sorry about it. Welcome on behalf of PediSTARS. Welcome you all to the very first nursing simulation meeting in India. So it's a very super special day for us. And we plan to do it every month on behalf of PediSTARS. And we just like most sophisticated ICs, but went out of our way to not just to teach herself, but also to teach the global community, help in formation of the IPSS, International Pediatric Simulation Society, and traveled across the world helping people, especially India and PediSTARS. She held our hand in the past 8 years and has been an inspiration to all of us and the nurses in India. So Ella Scott, I welcome you today to be the special guest speaker talking about how
I think we've lost Geethanjali, have we?
Yes, Ella. Okay. Okay. Hello, everyone. I'm really glad to see so many people joining in, and my professional colleagues who have taken interest in taking nursing to the next level, where we can make a difference at the patient's bedside and improve patient care. So without wasting much time, I would like to invite Ms. Ella Scott. She's a simulation nursing leader already. She's working in Australia, and she will be taking us through her journey, and she'll share her experience of being a nursing simulation leader, and she will definitely share some important tips with us, which will help us in to become a nursing simulation leader in the near future. So over to you, Ella. You can start sharing your screen. Thank you.
So before Ella starts, I would like to say that after Ella's talk, we'll have a Q&A, so we'll have the opportunity to speak to Ella, and then we'll have a research presentation in simulation, just to give an example of how to get started with the research, and what would you do, and provide your inputs, how to make it just a budding research idea, and it might have a 6, 7, 8 versions before it comes to the proper shape of proposal. So let's all put, so every month we will do this. Over to you, Ella.
Thank you, Dr. Geetha, and thank you, Smita. As always, it's a pleasure
I'll
to
share my screen. Right. So before that, sharing the screen, I would like to ask Ella. Ella, what made you embrace?
I'm sorry, I'm having problems hearing Dr. Geetha. Would you mind repeating the question, please?
Yes, Ella, if you can tell us what made you.
So I think you asked me, why did I want to do SIM? Was that the question?
Ella, I wanted to ask you what made you.
I've always had an interest.
I'll put it in the chat box. Yes, Ella, I'm sorry for the power disruptions. I would like to Smita to, in case if I get disconnected, to take over. Yes, Ella, if you can tell us what made you embrace simulation.
Thank you, Geetha. We'll try again. This is always the challenge of technology. I think what I'd like to say is my interest from simulation first came about patient safety. I think as nurses, being at the bedside all day, 8 to 12 hours a day, unfortunately, we do see some errors, we see some threats, and some of us have probably been involved with root cause analysis in determining why an error happened, whether it be human factors or systems issues. And as nurses, I think, and as a team with our allied health staff and our doctors, we are always aiming at giving the best possible care to our patients. We're always looking at how can we actually improve the care, how can we prevent incidents happening, and alongside that, I've always had a keen interest in teaching, research, and yes, teamwork. And simulation is a great tool for actually addressing some of these elements of patient safety, and also mentoring our more junior staff and looking at how things will change in the future with simulation.
Thank you so much, Ella. My next question to you is, could you talk to us your journey in simulation? How did you, from an intensive care nurse, how did you become the global leader in simulation?
Well, many years. As I said, it started with my interest in patient safety and teaching and research elements. And I think what happened, in fact, was there was a critical incident. I became involved in it from a root cause analysis. And we thought, how could we make this better for children? It involved a child. And then I was fortunate enough to meet up at a pediatric simulation conference with some global leaders in simulation in Florence. I think it was around 2008 or 2009. And they were a very passionate group. We shared the same interests. We were all involved with teaching. And that was sort of the beginning of a journey, really, where I became involved with the International Pediatric Simulation Society. We shared ideas, and I was fortunate enough to have the opportunity to take on inception of a new pediatric simulation program in Sydney at the Children's Hospital Westmead. I probably mentioned now I work at the Royal Children's Hospital in Melbourne, but I live in Sydney, so it's all very confusing. And through that group that I met, I managed to get enrolled in the Bristol-Boston simulation program. So I undertook this program in Bristol under Dr. Peter Weinstock from Boston. And it was a 3-day program. I learned a lot. It was a well-established program. And then along with this group of simulation enthusiasts, in 2010, we actually were the foundation board members of the International Pediatric Simulation Society. And this took place in Madrid when Dr. David Grant was actually chairing the International Pediatric Simulation Conference then. So that was 2010. And I think now we've got to 2021. So in that past 11 years, I think we've come a long way. And I continued at that time to be a member of the board executive for quite a few years. And things just flowed on from then. I became the manager of the simulation program at Children's Hospital Westmead. We spread our wings across the network, set up another sim program at City Children's Hospital in Randwick, and we became a bigger network. And from then, people came to us, we helped with curriculum. And following that, I went to help set up the program at Sidra Medicine in Qatar, in Doha. Again, another simulation program from the beginning. I spent 5 years there using simulation to actually help open a new hospital. And then I came back to Australia, and I'm working at the Royal Children's Hospital in Melbourne as one of the clinical nurse consultants. And again, very involved with simulation with all the departments in the Children's Hospital.
Thank you, Ella. In fact, I've known Ella since last 8 years, but I really kind of got to know her caliber and the way she goes beyond to help others. When I went to Sidra in 2017 and 18, she was helping to get the new hospital started. And she was there for a few years. We're literally simulating in 11 areas sometimes at a time. Is that right, Ella? And imagine supervising 11 different kind of simulation going on. One in the emergency room, one in the ER and the clinic and the ICU or the patient area. So it was just, mind-blowing how she managed to train everybody, delegate, and there were like participants or nurses and doctors from 87 countries. So to create a common language and make them care for the patient through simulation, it was just amazing. And she's truly, truly inspirational to all the nurses, not just the nurses, all the healthcare professionals, India and across the globe. Thank you so much, Ella, for that. My next question is, what was the greatest challenge in embracing or in becoming a simulation leader? If you can share some of your challenges, please.
Well, I think it's probably the same globally, Dr. Geethanjali. I'm sure many of you out there are balancing work life, family life, clinical commitments, on-call duties. We have over the past year, the challenge of COVID, which has struck us all. So I think, as usual, it's time. The other thing is working with or being part of IPSS and PediSTARS, and I'm very grateful to be part of PediSTARS as well. It's been a great journey for me. But one of the challenges is we have this passion for simulation. We well and truly believe in it and we want to make things better. Talking to our international colleagues, time zones are always a challenge, aren't they? Because we speak to everyone all around the world. And as I mentioned, trying to keep up our normal commitments every day with our positions of responsibility that we carry, and our home life, our personal life, our social life, is a true challenge in this day and age. And I think this is probably the common denominator across the world at the moment. So I would certainly put time zones and time at the top of my list as challenges. 10 years ago, we had challenges with probably some of our stakeholders, really, because there are workforce issues. Again, it was trying to get curriculum going and scenarios and faculty development and sustainability with a workforce that also has to look after patients, and our patients come first. So actually, the logistics of liaising with our executives, our managers, and embracing simulation as a tool for the future and our outcomes in patients has come a long way, I think, in 11 years. Now it is recognised all around the world as a valuable tool. So I think initially that was a challenge. I don't see that as a challenge now because we have results, and that is improved patient care.
Thank you, Ella, for that. You know what my next question is, my favorite question. And yeah, the challenges, it's not, it may be past challenges for you, but for India, most of the challenges are, I think it's a global. And it's great to, thank you for sharing that. And I think we are all in the same, if I can't say same boat, but the similar boat, but some of the challenges even more, but I'm sure it's an inspiration for all the nurses here. And I would like to ask you, how did you overcome the challenge? What is the best part of being a simulation educator? What do you feel really proud of? Oh, I'm so glad I took up simulation.
I get a lot of participant feedback over the years, which does eventually go back to our patients. I think, as I said, being involved in research, making things better is the way we have to move forward. And I think also this is a team effort. And what we have embraced over the past 10 years is, I think, a greater involvement with our multidisciplinary teams, our allied health workers, our physios, our occupational therapists. The whole healthcare team is involved. And what I've seen is a move from the medical and nursing area to allied health, and embracing our allied health colleagues and all working together on a curriculum which is a holistic approach to the patient. In the old days, nurses learnt with nurses, doctors learnt with doctors, and each allied health specialty, of which there are many, all had their own training, which of course they still do within their own specialties. But now I see much more of a cohesive approach through simulation. And I think that makes us work much better as a team.
Ella, that is so enlightening, because I think in India we are still 10 years lagging behind, and it will take us hopefully not too many years, because people like you coming to India and helping us and talking to us now virtually. I think this will all help them, the nurses and even the doctors, to climb the ladder pretty quickly and close that gap. And yes, PediSTARS from the day one, our first faculty development program, we wanted to invite the nurses to become the participants and to become the faculty. But there was so much resistance across the India. You people don't know PediSTARS, you don't know what you're doing. The nurses will feel overwhelmed. You can't have together faculty development for the doctors and nurses and the allied. And we said, there's no way, there is no negotiation. We have to have the nurses because they are the pillars. But still, the gap has reduced now, because we've been actively kind of trying to get our nurses empowered. But we still have a long way to go. And thank you so much for sharing. Coming to Indian nurses, I would like to share some pictures of Ella.
I think you've come a long way. And I think you've got some great nursing leaders. Some of them are in this photograph.
So yes, yeah. So this is Ella helping the faculty development. Behind, you can see Mike Shepherd and Rashmi Ramachandra from AIMS. And this is every stimulus she has been coming, hand-holding us, hand-holding the nurses. And this is a great picture, Ella, from your current working place. And that's a very nice moulage. You are an expert in moulage, and you taught everybody in India as well. So it's very, very impressive. Thank you so much for that. So let me stop sharing my screen and we can look at each other. So Ella, my next question to you is, what is your advice to, you have come to India so many times, physically and virtually, and I have talked to you for hours and hours about our nurses. What is your advice? And we're all looking at you to train us and also give some tips. What's your advice to them? How can they become simulation leaders in India?
I think you need your key nurses, your key nurse leaders, nominated leaders, and you already have some. And I've had the pleasure of working and teaching with some of them that I recognize the names. I have seen you all in person, so I know you're out there as leaders in simulation already. You are the team that are going to take this forward, working with your physicians and your allied health staff. So I think cascade training is something else which you're already doing. So have a sustainable faculty. And again, I know many of you have done the PediSTARS faculty development program. Some of you have successfully completed levels 1 through to 3, which, if you think about it, over the past few years is an amazing achievement in itself to get this number of people up to level 3 in faculty development. So these are your leaders. You are the leaders. You're here already. So you've got a start. And you're doing an amazing job. I've just been looking at some of the work that's been put together by PediSTARS over the past 10 years. So you're out there, you're on the map, which now you just need to look at the future. And with your faculty development programs, you need to embrace and mentor more nurses, both undergraduate and graduate nurses, and foster research and look at measurable outcomes from simulation that will help our patients. And as you know, all of you out there, I'm more than happy to help with this, but you've come such a long way in the last few years. It's quite phenomenal. And I think also often we focus on critical events or incidents, which is one part of simulation, but also we can look at other elements in simulation, whether it be communication, whether it be the holistic approach. An example would be going to help with a lumbar puncture on a febrile baby. we all know that holding a sick baby for a lumbar puncture, as a nurse, I've always been petrified of this for many years, and I've been doing it for years. But if I'd had the chance as to what we have now with the different elements that are involved in just positioning a baby for a lumbar puncture, which will make it so much easier for the physician to get the needle in the right place. We can teach this at undergraduate level, but we can also teach it as a holistic approach, as a communication, speaking to the parents, rehearsing informed consent and communication, as well as the practical procedure, and alongside adhering to the nursing procedures that are written. And this is something else that can be measured through simulation, which I think we're going to talk about a bit later in research. So I think my take-home message would be certainly a sustainable simulation workforce, mentoring, and helping to build curriculum and scenarios for common cases, everyday cases, as well as the uncommon cases, and look at new departments. You mentioned Sidra and all of our experience, Geetha, with opening new departments, simulating absolutely everything and validating everything before we could put a real patient within that department. So if you hear within your hospital that a new department's opening, get in there quick.
Thank you. Ella, what I gathered to summarize what you said for the last, my question is key is a faculty development, right? So you need to become a faculty competent faculty depending on who your learners are. And that is a main thing. And you also mentioned it's important not just go on training, but also do some research, what works for you, and find out what others are doing and collaborate with others. And that's so powerful. Thank you so much, Ella. I think what we'll do is, Ruchi, if you can focus on everybody so we can look at each other and ask questions to Ella. I'm sure you all have lots of questions to ask you. So Ruchi, yeah, you can stop spotlighting at all, so we can just have a chat, and then we invite all of you to ask questions to Ella. You can either put in the chat box or you can start speaking. Thank you, Ruchi. Okay, shoot off questions. You can write in the chat box or ask. What's your questions to Ella? Smita, do you have any question to Ella?
Hi, Ella.
Hi, Smita.
So my question to you is, like in India, we have very few nursing simulation trainers. Last time when we had Simula 6 virtual meeting, Miss Lydia, she said that there should be some, the simulation training should be made mandatory. So do you have anything like that in your country where you have made simulation mandatory for all the nurses, or it is, just done when and wherever it is required? So do you have some, what do you say, the contact hours that you give to the participants who are, attending the simulation training or something like that?
That's a very good question, Smita. And I think if we're talking about nursing, we have to differentiate between undergrad and postgrad. So in the undergrad world at university here, skills training and simulation and scenario based training is part of the curriculum. So it's a recognised part of the curriculum at undergraduate level in most of the universities now, I think. Now, I work in a tertiary children's hospital in Melbourne, so our work is a lot with postgraduate nurses, and a lot of it is within teams, within departments, as well as communication type programs as well. So we have the skills the specialized scenarios within departments like emergency, anesthetics, that will involve the whole team. So there'll be graduate nurses and also physicians doing their fellowship training and allied health staff as well. So it's very much a graduate program that I'm currently working in, but certainly on an undergraduate remit, that would be part of the mandatory curriculum, yes. Did that answer your question?
Yeah, thank you so much, Ella. I just want to know how many hours have you given mandatorily to the undergraduate training?
Do you know, I actually can't answer that question because I'm not involved with undergraduate training at the moment. Certainly at Sidra, there were a significant number of hours of undergraduate training, depending on which module and which year they were in. So it's actually a little bit different in each university. And because I'm not teaching at undergraduate level at the moment, I'm sorry, I can't tell you the amount of contact hours.
Thank you, Ella. So since we have so many nursing leaders right now attending this meeting, so this is a kind of point to brainstorm and know how can we actually put, you know, the simulation as a mandatory, give simulation a mandatory hour in our undergraduate program. So because we right now do not have any mandatory hours given to simulation. So, so this is a
great question, Smita. I would like to hear from others. What do you all think? Do you have any mandatory hours now for the nurses simulation, or you're planning to? I would love to hear from other nursing leaders and also Dr. Vijay and Sujata, please.
Geethanjali, let the other nursing leaders say first.
Yes.
Good afternoon, all.
Thank you. Yeah.
So we do have kept mandatory hours for the total training. So in a month, for me, if you ask, at least 3 to 4 simulation trainings we are taking, not in a full-fledged, but going forward, trying to make multiple simulation leaders internally, and then we would change it. That's our plan here.
So have you integrated simulation into your training? Are they getting CME hours, CPD hours? Neelaveni?
CME hours provided to them. We have still not done the thing with nursing council, ma'am. So that nursing council credit hours, we are working on it. I think it will be done from next month, 15th or so.
Okay. Mumtaz, would you like to add anything to it? Rimple?
Yeah, ma'am. Hi, ma'am.
Hello.
If you ask me that is the simulation is there in your training? Yes, it is. When it starts from your nursing induction itself, we have a lot many procedures to show to these new joinees. So it has already been every procedure when I am teaching to them, it's a simulation based. If I wanted to show basic CPR skills, it is a simulation. So every month we have these mock drills conducting for a CPR. So it is doing in the same way what we have learned in level 3. And the same time we are doing a debriefing and take home messages. So it is really, really very useful to decrease the rate of CPR being in the ward, and they are recognizing the sickness of the patients in the ward. So this is how the simulation has worked in many ways to decrease the CPR in the ward and early recognition of a child and shifting the child early in a PICU state where we can save a life.
Mumtaz, that's really inspiring. So you reduce the number of CPRs or cardiac arrest in your hospital by training them in the simulation. Mumtaz is one of our level 3 nurses, faculty development program, PediSTARS. And I have seen her grow and known her since, I don't know, maybe 25 years. And embrace the simulation and putting her heart and soul into it. I'm sure if Mumtaz, who did not have any background in the simulation, she can do it in 2 to 3 years. All of you can. You're a really inspiration, Mumtaz. Thank you so much. We would love to hear from other nurses. Share your ideas to others and how you overcome the challenges, please.
Great to hear from you, Mumtaz.
Yes, good to see you.
Poonam, would you like to say anything? Do we have Lata Sharma?
Hello.
Dr. Lata?
Hi, Ella, and it's very nice to hear from you the type of development you have on simulation in your setup. We are right now 5 faculty trained in simulation, and we have successfully completed level 3. Due to COVID last year, we could not do it. Again, we have a plan to restart this in the form of our regular activities for our students. However, we do not have simulation as mandatory one. But since we are sensitized and we are already into it, so we would like to run more and more simulations in our college. The only problem we are facing right now is our clinical counterparts. They are not yet sensitized. So this is one area which we have to work on, and we have to spread this message to the clinical side so that the in-service education department comes hand in hand with us and make simulation a regular exercise, especially at the time of induction, as it was suggested by my previous speaker. They have been doing at the time of orientation. So we also would like to take forward the simulation for our students as well as for our clinical nurses.
Awesome. Thank you so much. We would like to hear from the other nursing leaders, please.
Hello.
Hi, ma'am.
Yeah.
Yes.
Hi, ma'am. Myself, Raji from Master RV Hospital, Bangalore.
Hello.
Yeah, ma'am. Means our hospital, like PIC step down, like newly started unit. So here, like nano simulation, we did like means how arranging the intubation things and all. So we ourselves only we did nano simulation. We targeted some time like 2 to 3 minutes. Means we targeted, and daily, day by day, we were like practicing like how how fastly we are arranging the intubation things and all, like before patient comes. We started so we were doing that one. So it was like after once we received the real patients, no, it was very useful to us, like where the things and all is there. It was very useful for that actually.
I think that sounds like an excellent example of using simulation to become familiar with your clinical working environment, and again, adhering to patient safety. Practice where everything is before the real situation arises. And the other comment I would make, just coming back to time, is many of you would have heard about just-in-time simulation as well. So often when we think about scenarios in simulation, we think about programs of a few hours or a day. But if you have one specific element in your mind, maybe it's a procedure, you can actually use just in time when there's a quiet time in the ward, if there's ever a quiet time, and use that time as an opportunity to run through something just in time. So it might take 15, 20 minutes, and you can do this repetitively. So just in time simulation is something that's worth thinking about in the Indian context, I think.
That's right. Thank you. We have great comments from in the chat box there, and there's one comment from Singapore, Nagamal, that it's a 15%, at least 15% of the curriculum, nursing curriculum, it should be delivered to simulation program. I think that's wonderful to hear. I'm sure India can do it one day. So any other questions, any other thoughts? Or shall we
Good evening, ma'am.
Hi, everyone.
Good evening, ma'am.
Hello.
Hi, Rebecca. Or is it Kamlesh?
Hello.
Okay, let Rebecca go. I'll join later.
Hello.
Yes, Rebecca, carry, go on. After you, Kamlesh.
Hello.
Yes, we can hear you.
Good evening, ma'am. This is my name is Rebecca.
Hi, Rebecca.
Yeah, ma'am. I work in AIMS Patna right now, and before this, I had been working with NGO called as Care India, where we were aligned with Pronto International. So here in this Pronto International, we actually concentrated on emergency care of maternal and child health, where we used low tech instruments for low-tech supplies for teaching the government nurses under a project called as Amanat to how they can take care of emergency conditions in during delivery and during neonatal care. Like just now, Ella, she said that we can use this just in time. So our project somewhere we learned about how to use just in time. That is, we used to do on-hand trainings in the clinical that cold hours in the clinical area where we used to use simulation. So why am I saying it here is because the same thing which I had learned from that project, I had used it with my students here in like the 4th years. So specifically in the labor room, when the labor room is cold, I used to use the scenarios, and because we already have a developed scenarios of all the maternal emergencies, I tried to use those things with my students here, where the feedback from what I got from my students, where it was very easy for them to remember the follow-up steps of the emergency during the emergency conditions. That is, like if one thing is not working, for example, during shoulder dystocia, if one technique is not working, how they have to just go on skipping to the other one. So that's how it was very useful. That's what I wanted to share with you.
That sounds
Thank you,
fantastic.
ma'am. Thank you,
Thank
ma'am.
you, Rebecca. Yes, I've heard of this program. So it's really wonderful. It's been going on for some years, right?
Yes,
we'll
ma'am. I have been
yeah.
I have been working with them for past 4 years. So I just made a use of it with my students here. It was really helpful.
We had a combined meeting here in Hyderabad a few years ago. We'll take one question from Kamlesh, and then Smita is going to present a very simple research to get started for the nurses, and then we'll continue our discussion after that. Kamlesh.
Thank you, Dr. Geethanjali. Hi, everyone. This is regarding making simulation mandatory. Actually, to my understanding, Indian Nursing Council has not yet actually given the go-ahead like to making it mandatory. And it would be great if we can have it from that end. Otherwise, people will be doing sporadically here and there. And basically what we see is mainly whatever simulation is happening. This is more so into MCH, that too into pediatrics more, and then critical areas. The rest of the areas, it seems that there are still more challenges and it still needs to make inroads there.
Absolutely. I totally agree with you. The nursing simulation is not made mandatory, and it's not just India. There are many other countries struggling like this. But what if they make mandatory? Are we ready? My answer is no. The same thing happened in doctors. They said, yes, it's mandatory. Everybody should have the simulation lab. So people purchase crores of worth simulation lab, and it's all locked up because no one knows how to run it. There are no faculty. So the key is the people who can make it happen are you. So you become the faculty, you start doing, and then you put forward your ideas. I have a conference, annual conference, just like the PediSTARS, the nursing conference, and do lots of activities. Then there's no way the nursing council will say, no, we won't make it mandatory. So don't give them a choice. So all of you, I request you to become the faculty. We'll have monthly training, or if you become the PediSTARS member, then you will become part of the WhatsApp group, and we will guide you how to go about it. And Ella and quite a few international nurses are there. And then to the faculty development, to continue to do just like how Mumtaz is doing, how Smita is doing. If you continue to do, there is no way India can say, no, let's not have it. They have to make it mandatory. Thank you for bringing it up. So now I request Smita. Smita Das is one of our level 3 trainees. Faculty development program is level 1, 2, 3, where you get the certification after tough training for 1 year. And she's also joint secretary of PediSTARS. So she's created a very simple extremely simple research. All of you can do it. She's going to present it in the alert format. That is the Inspired Alert. Inspired is a research branch of IPSS, International Pediatric Simulation Society, which started with Ella and other doctors and nurses across the globe. So she's going to present it in an alert research format for 5 minutes. Then we'll all give her inputs how to strengthen that research and make it a research proposal. Smita, over to you.
Is my screen visible, Geetha ma'am?
Yes, if you can make it look slightly bigger and
Yes, it's visible.
yes.
Thank you, ma'am, and thank you, everyone. So the title of my study is Impact of Simulation-Based Training on Needle Stick Injury Among Nursing Students, Low Resource Country. Here are my co-investigators, Ms. Levis Murray, Dr. Poonam Joshi, Ms. Rimpal Sharma, and Dr. Lata Venkatesh from All India Institute of Medical Sciences, New Delhi. Needle stick injury and sharp injuries are major hazards in the transmission of bloodborne diseases, and our nursing students during their clinical posting are at increased risk of getting a needle stick injury. There was a study done by Derek R. Smith in the year 2005, where he has reported that almost 13.9% of nursing students had needle stick injury or sharp injury. Simulation is known to improve the safety culture, but there is no such studies being done in India yet. So the aim of my study is to reduce needle stick injury incidence, increase awareness regarding safe injection practices among nursing students. My primary objective is to assess the impact of simulation training on knowledge regarding safe injection practices among nursing students, and to assess the impact of simulation training on adherence and confidence related to safe injection practices among nursing students. The secondary objective is to evaluate the impact of simulation on reduction in the incidence of needle stick injury after the training. The population that I'm taking is third-year nursing student. They are 17 number at AIIMS New Delhi. Intervention will be simulation-based training conducted by, which will be done by PediSTARS trained level 3 certified trainers. They are 4 in number who are involved in the study right now. I do not have any control group. It's just a one group pre-test post-test simulation. And the outcomes that I'm looking for is improvement in knowledge as assessed by knowledge questionnaire, improvement in adherence as assessed by the practice checklist and self-report, and reduction in the incidence of the needle stick injury. My sampling technique will be convenient sampling. Design is quasi-experimental one group pre-test post-test design. Evaluation is knowledge and adherence and confidence level, and also incidence of needle stick injury. The research type is quantitative, and I'm also planning to use qualitative method to know the behavior and to know the confidence level of the students. So this is how I'm going to do my study. First, I'll do a need assessment and look for the incidence of needle stick injury in the past 2 years. And then we'll design a scenario with the help of the other trainers. A baseline knowledge and skill regarding safe injection practices will be assessed before the training. And after the baseline knowledge and skill has been assessed, simulation training will be given in a group of 3 to 4 students, which will take around 2 weeks. And after the training is being given, an immediate post-test score of knowledge, skill, and confidence will be assessed, and the retention will be checked at 3 months. So knowledge, skill, and confidence, all the 3 components will be assessed again at 3 months, and the needle stick injury incidence will be assessed over the 6 months after the training. So these are my timelines. So I'm hoping to present my alert in September, and ethical submission by August, and recruitment and data collection in December 2021, and data collection and analysis between January to June, abstract by July 2022, and manuscript by August 2022. These are some potential barriers to the study implementation. One is there any validated checklist for assessing the practice related to safe injection practice? And since we do not have any reporting system for needle stick injury in AIIMS, assessing the impact of real patient in the real patient area will be challenging. Few questions to improve the study. Is there any better way of simulation training to reduce the needle stick injury? What is the best way to evaluate such study, and how do we introduce needle stick injury reporting system? So that is all about the study that I'm wanting to do. Kindly give your inputs.
All right, thank you so much, Smita. You can stop sharing the screen now. Let's have a discussion over it. Smita, if you can just summarize in 2 minutes about your study and your potential barriers again, please.
My potential barrier is one that we do not have any validated checklist to assess the skill, which I'm planning to make it, because till now we do not have. So if anybody has any idea of any validated checklist already being used to assess these skills related to safe injection practices, I will be happy to know about it. And the other barrier that I feel is we do not have any the reporting system of needle stick injury in our hospital. So how do we ensure that, how do we see whether our intervention has actually reduced the incidence of needle stick injury? These are two barriers that I feel are there to, so others can actually comment, how can I go ahead? How can we go ahead overcome these barriers?
All right, thank you, Smita. Now first, yes, that is her barriers. So keep them coming in the chat box. Now let's go to the study design. If you can share the chart about your study design. So we want to invite all of you to provide your critical comments on her study design. Is there any way we can improve that study? So can you put the first slide, please, Smita? So this is about, I would like to ask all of you, is it something you feel is important, something relevant to you? You can write yes or no in the chat box. Do you face this in your department or in the hospital? So needle stick injury. So can we do something about it to the simulation? So can you put the next slide, please, Smita? So this is a background. Yes, so her objectives are to reduce the needle stick injury incidence, increase awareness regarding the safe injection practice among nursing students. So this is just an example. So you can do this for anything, any other area you think there is a risk or the gap, or you feel you need to train, you can make it a research project, and then you can present it international. Smita is going to present in the international conference soon in September, and then get inputs from all the experts. And then you can do the study and then publish it one day. So in India, there are lots of theses being done, not even a fraction of it gets published because we do not have a very solid study method or design. That's the reason we are providing you international help to make your study robust. So her primary objective and secondary objectives are clear there, to assess a simulation training on the knowledge, and also she wants to see how it's impacting in the real patient care area. Has it reduced a needle stick injury? All right, next slide, Smita. So population, the nursing students, intervention is a simulation training by the experience. That is very important. Unless you're a simulation trainer, then it will not be complete, because the debriefing is a key of simulation. You all should master that art of debriefing and the curriculum design. What kind of simulation you're going to do for what kind of learners. And there's no separate control group. It is just a pre and post. So the outcome is improvement of the knowledge, skills, and also on the needle stick injury. All right. So next. I'm just going through again because we have only 5 minutes present in the alert, and I felt it was probably rushed for you all because some of you, this will be the first alert presentation. So the sample, she is going to take 70 nursing students, and I want to ask you all, would you call it as a convenient sampling or something else would you name it as? My next question is study design. Are you okay with the study design, or would you like Smita to design in a different way? And evaluation, is she okay in thinking this is how she's going to evaluate, or do you have any other inputs to her? And regarding the research type, keep them coming in the chat box so we can have a discussion. Next slide, please, Smita. Next slide, please. Yes, so this is how she's planned to do. First, she has to find out what is the current status of the needle stick injury. Is it huge or is it none? Then probably you don't have to do the study. And then the scenario design or curriculum design is very important. How are we going to just do the skill-based, or are you going to do the complex, the immersive scenario, or are you going to do the skill first and then the immersive scenario with the debriefing, mix of everything? How many students you're going to have at a time? How many facilitators? How often you're going to spread it? All this should come in the curriculum design. So that takes a lot of time to discuss with your team and also to ask some expert. The study design is a key of any research and the future publications and where others can replicate. And so what she's planned to do is after study design, she's going to do the simulation. So just before the simulation, she's going to, not just Smita, it's her team, Levi's, Poonam, Lata, and Rimple. They're going to assess the knowledge, skills regarding the safe injection practice, either questionnaire or in the mannequin, put a mannequin and see what they do, and then do the simulation training. Again, we need to discuss whether you're going to do the one scenario or you're going to do two scenarios with increasing complexity. Are you going to do plus delta debriefing? Are you going to do RCDP, or are you going to do advocacy inquiry? And how long is the simulation is going to be running for? And then how do you test them? Post-test, their confidence level, skills, and assess the needle stick injury post-simulation, and then write the manuscript. Okay, you can stop sharing the screen now, Smita. Right, so we want the inputs from you all. Some of you must be very experienced or regularly doing research. We need inputs from you so all of us can learn.
Ma'am, hello. Can I just say a few words?
Yeah.
Hello. Ma'am, you mentioned about sampling technique. I think it would be appropriate to call it total enumeration rather than calling it convenient sampling.
Sorry.
Hello.
Can you, yeah.
Hello.
Repeat that again. Sampling should be called.
I'm saying it should be called as total enumeration technique rather than calling it
type,
convenient.
Poonam, your Wi-Fi is not very, you're breaking down. Can you type, please?
Okay, and ma'am, I'm moving out.
Yeah, keep
second
typing message.
Yeah, second thing is we do not have checklist right now, but we have standardized material. CDC guidelines are there, so based on that, I think we should be able to develop the checklists.
Brilliant, and that is a validated checklist?
We'll get it validated, ma'am.
So any checklist has to be validated nationally or internationally to be able to replicate tomorrow if somebody else wants to do the study either in the UK or another part of India or Nepal. It has to be validated.
Yes, we'll do it in a systematic manner, validation part.
Okay.
And regarding the reporting, you said we do not have, Smita said we do not have right now any structure available. See, there is a reporting system available, but our students, they might not be aware of it. So during the study, we are going to sensitize them.
Excellent. So what we need to happen, Poonam, is we need to have the incidence of needle stick injury before you do the study.
And she did it.
So sensitization should happen now, probably tomorrow or day after tomorrow. Then you encourage them to report it and then do your needs assessment.
Yes.
Once you get the injury or incidence details, for example, road traffic accident, they're happening, but if nobody's reporting, I can't do a study tomorrow. So I would request everybody to report, the police to report, people to report to the police to report to the government. So we have a statistics and then only we can do the study design. Otherwise, we don't know what to do in the study. And also not just reporting, it's good to interview some of them who are saying they had needle stick injury. How did it happen? Where did it happen? So you can design a scenario accordingly. Instead of a standardized scenario, you need to recreate that. How did they get a needle stick injury? You need to recreate that scenario. All right. So, Poonam, any other inputs, or we can move on to other participants?
That's all from my side.
Thank you. Thank you. That's very valuable, Poonam. Ella, do you have any inputs for the study?
Sorry, Geethanjali and everyone, I have to leave soon just to talk to the UK, but I wanted to thank everybody. I think that was a fantastic presentation. Thank you, Smita, and your team. And you clearly are leaders in simulation already. The quality of that study looks great to me. The question, I'd love to look at it in more detail and have a chat, but I'm interested in two things. One, you mentioned the incidence of needle stick injury is not recorded, or did I misinterpret that in terms of gathering your data of actual number of injuries over 2 years?
The incidence reporting system is not very well aware for, our students are not aware of it basically. So we do not come to know how many of our students have, undergone needle stick injury, and they have had needle stick injury. So when I had to know the incidents, I had to, go to each student personally and ask them whether they had any incident of needle stick injury. So in order to see the efficacy of my training, I need to have a format where I can get these incidences reported, systematically. So that is what I feel is the challenge which I'll face. So when we discussed this with our principal, she said we need to have an incident reporting for our students in our college, so that whenever they have any needle stick injury, they should be reporting in a systematic way. So there has to be a format in which they have to give the information. How did they get it? What were they doing? What procedure they were doing? So all those things. Yeah.
I think your perseverance is admirable, I have to say, because that sounds like a lot of hard work, and I'm truly impressed with your commitment to making things better in that element.
Having said that, Smita has been talking to, and there is a lot of incidents, right? And though it's not reported, she has got informal feedback that quite a few have been. What's the percentage, Smita, of the nurses getting?
Around 20%.
20%. So we do have some idea, but it's not formally reported. Ella, thank you so much. I know you have to go now, and thank you for staying for the whole session. And we hope to see you again. And I hope there will be a lot more nurses coming out to become like, if not like Ella, but similar to Ella, the leaders. And one day in the same platform as Ella, in the international platform, presenting their research and their work in the simulation. Thank you so much, Ella. We request others to stay back if you can, so we can continue the discussion. The great discussions are happening. Thank you so much, Ella.
Thank you for having me, everyone. It's been a pleasure, as always, with this group.
And we won't let you off. We'll keep inviting you. All right. I request others to provide inputs regarding the research proposal, SMITAs. We want to hear from other nursing leaders, please, and also from Vijay and PediSTARS faculty, Sujata.
Hello, Dr. Geethanjali. Hi, everyone. This is Rupal. And
hi, how are you?
Yeah, I am good. Thank you so much. And a small suggestion from my side regarding the proposal that Smita presented. Like she's been talking about incidents. Suppose if we try to find out the incidents prospectively, then we'll have to wait to start this project. Like for a year, we'll have to see the incidents first and work on the baseline first, get baseline data first, and then we can implement the project and get the post-test and or post-intervention data in order to compare this. So just my suggestion is that can we, or I'm just asking this to you, can we gather or collect retrospective data from like all 4-year students and start working on this project?
Yes, I mean, this will be retrospective only. What I meant is tell the students there is a system. So if you had a needle stick injury in the past 6 months or 1 year, please report. So this will be kind of retrospective only, Rimple. It's not prospective.
So on this data,
no, to understand every month how many needle stick injuries, okay, all may not. So the key thing is, I mean, all of us struggle with this different reporting, even the doctors, because they are worried that they'll be penalized. Why did you have the needle stick injury? But if you can assure them that this is to protect you, this is to help us to understand how we cause needle stick injury to you. Don't say you cause needle stick, how we cause needle stick injury to you. You want us to come in and tell in the last 1 year or 2 years, have you had any needle stick injury? You roughly remember when you had it. How did it happen? Then that is creating a safe environment. All of them will come forward to tell, if not all, most of them. Yes, Rimple, that is a long answer to your short question.
Thank you.
Any other thoughts regarding how to strengthen the study? Is she in the right track, or should she change her study design? Nipin, would you like to say something?
Nipin is saying that it will be difficult to get retrospective data if AIMS Delhi does not have any reporting system.
Yes, what Rimple meant is not retrospective data, retrospective reporting.
Yeah, same. Thank you very much. Same, I would like to mention that once they do not have reporting system, then actual data will not be able to get. And unless and until if we have actual data, then you not compare, data or post exposure, whether they had a needle stick injury or not. So that will be one of the difficult part over here. The second one, once you have one validated checklist, then you can see the postly adherence to that checklist, whether they're following the guideline or not. So I think that can be done.
Yes, I totally agree with you. So it's a wake-up call for all of us, right? We have so many policies, protocols, but it's not followed. Even in my hospital, simple things swap. So unless we dig it up and say it's not just somewhere in the software, it has to come to the bedside and encourage them to do it. Mainly the critical incident reporting. We will not progress. So probably it's a wake-up call for all of us to look into our protocols and say, are they actually aware of it, or they're actually aware of it but still do not want to report why? And so we have to start somewhere. Yes, this will not be a perfect study, but we are starting somewhere. Shaila, would you like to say something?
Yeah, good afternoon, ma'am. I'm from Ambani Hospital. Yeah, we are, 750 bedded hospital. We have done a needle stick study with the collaborate with the infection control department. Before developing this, we have developed the form, and then awareness is being put up in all nurses station. So needle stick injury has to be immediately informed to the nurse manager, and the person who has got in needle stick injury, either it's a doctor, housekeeping, or a nurse or HCA, should be guided to go to the accident and emergency. There the doctor is taking a history of a patient and the nurse's vaccination, and the counseling will be done. That is how we have done. And then every month there is a 30-minute session on a needle stick injury, how to pick up the needle. Like the person who insert a IV line, whether it's a doctor or a nurse has to pick up a needle and put it in the container, because they should not be transferring. That is, if the needle goes from one person to the another person, there is a high chance of a needle stick injury. So I think over a year, a lot improvement we have seen, even though we are having a highest nurses attrition, but the needle stick injuries are much reduced.
This is beautiful, Shaila. Thank you so much. I would like, with the interest of time, all of you to, I have put Smita's email there, provide your inputs or queries to her email. And if you're doing a similar study, write to Smita. You can do a probably multi-center collaborative study. I have put her email in the chat box, and also you must have got email from her. So the more we do in the collaborative multi-center, the more stronger is the study. So if any of you would like to do a similar study and collaborate, please write to Smita, or you can write to me or PediSTARS@gmail.com. Thank you so much, Shaila, for that. So any other thoughts regarding how to improve the study? Thank you, Shaila.
Yeah, welcome.
Vijayanand? Do we have Rashmi Aradhya or Dr. Lata Sharma here? Jaslina, any thoughts from you?
Hello, I'm Jessie from Madurai. Hello. Good afternoon to all. Just one clarification related to this. Whether the extraneous variable is controlled, how going to control the extraneous variable.
Such
And
as?
that is, yeah, it needs to be very clear so that it will be more focused in the study. Thank you.
Sorry, can you explain what you meant? Can you give some example? What did you mean by it?
Like, yeah, extraneous variable needs to be controlled in a study.
No, such as, can you give some example what variables you're talking about?
Yeah, like variables like what I can tell you that only just you're evaluating the students, isn't it? How the injections, and other people can also handle the needles, like disposing in the biomedical waste. So that will come under the extraneous variable. How we are going to control in a study needs to be looked into it. Like for example, connecting the IV, like in that also needle will be there, no? Some like injections will be put in that bottle, and then that
I
they may
did
not
that
use
once 10
yeah,
years ago. Yeah.
yeah, they will not use that, but it will be how they are going to burn that in the needle burner, whether they're using it, how they are going to dispose that. It can be used by the A&M staff or other also, how they are handling. So I think that all will come under the extraneous variable, how we are going to control in a study.
I really did not, probably we can talk to the email, can message me, because this is about you're training them in preventing the needle stick injury and then see if it's improved the needle stick injury incidences. So we are not having a separate control population and the study population here.
Okay, and one more thing I can just tell that, like when you're collecting a data, no, can just specify that whether it can be in the clinical data or in the demographic data. Like collecting in the clinical data, we can just control. When we add that type of questions, we can control the extraneous variable.
But how is this study going to affect that? I'm curious to know.
No, that
Explain to me if I'm being thick.
It is more focused. It is need to be controlled in the, because we cannot just blindly tell that only the students is using and then it is getting an injury. Once the students is used, if she failed to dispose that needle, and the other person can also get that because of her. The usage may be done by the BS nursing student as a sample, but it can damage the other people also.
Someone
So
else
how,
can.
yeah.
Yes.
So that how you're going to control that, I'm just quoting as
So
an extraneous variable.
that is why Smita is taking her team 3 months for curriculum development. They're going to understand the needle stick injuries, study them, and develop a curriculum depending on that. So you need to have a scenario for each one of them. So it's not just accidentally seeing somebody else cause a needle stick injury to the third person. So all the scenarios should be included in the curriculum design. That's why it takes months to design the curriculum.
Okay, thank you.
Yes. So
Thank you.
it's not part of the simulation training program. They have to undergo all this. Just like a pilot is not taught just how to fly. They are taught how to crash land in emergency, how to fly through the storm, and how to fly when there is somebody trying to hijack the plane. All this they have to simulate, then only they are allowed to fly. So the same way we have to simulate everything, all the possible variabilities, and then only we can say our simulation training is complete. We may not be able to do all of it, but some which is a pattern. That's why we need to study the needle stick injury and see the pattern and create the simulation scenario accordingly.
Okay, thank you.
Thank you for being there. Jaslina, any thoughts? I think we are 12 minutes past. If there are no questions, probably we can, from the study, we can come back to the nursing simulation. Do you have any questions? You can write in the chat box or unmute yourself and feel free to ask. If you have any questions about how to become simulation leaders, how PediSTARS can help you. We have the PediSTARS faculty here, quite a few nursing and doctors, so we are more than happy to take questions.
Good afternoon, everyone.
Hi,
Can you hear
Jasleen.
me? That one, ma'am. How is the training of the facilitators going to happen, ma'am? Facilitators.
Yes, basically what we're doing traditionally is the faculty development program every year or twice a year. Now we have realized that that is not enough. We need to do more frequently, but the COVID came and it has kind of destroyed everything. So we are in the process of creating a virtual faculty development program. Our traditional faculty development program is for the whole 1 year. We do 2 days of simulation conference followed by 2 days of faculty development. In one of the, we have done in the AIMS, we have done in PGI, we have done in Chennai and CMC Vellore, Hyderabad, and Hyderabad twice rather, GVK MRI. Then afterwards we have, that is called the level 1. We don't give certificate of faculty development that time. We just give the basic certificate, and then you'll have to do 6 to 8 scenarios. Mumtaz and all have gone through, they can help you. Locally, depending on what your learners are, we will give you scenarios. You need to conduct those scenarios. Just a basic mannequin, you do not need high technology mannequins at all, but we can train you how to make it look like the high technology or high fidelity, what we call high realism, using moulages and the low cost or zero cost apps. And then see the learning happening there. And then the phase 3 is after 6 months, you need to do some write up about your journey, which everybody enjoys, and do some literature search, just like how Smita has done, and how some of the manuscript or literature out there can apply to you, write about that, or review or simulation literature. And also you need to do the needs assessment in your hospital, just like how Smita says, needle stick injury is one of the things. You need to identify 2 gaps and then develop the curriculum for that. You have to start from the, we won't give you scenario, you have to script the scenario, you have to run it, you have to debrief and give us a report. So that is a whole journey of a level 3 training. But we understand all of you may not be able to dedicate that whole 1 year in doing the intensive training. This is to become the national trainer. But if you want to become the local trainer in your own center, then we can modify it, and we will be coming up soon. We will inform you in a few months' time. Online training to become, it will be not the 1 year, but the 3 months we will be mentoring you. You can have a 1 week of preparation training, then 1 day whole intensive training in the simulation to the virtual training, and then 3 months of mentorship. So we will announce soon when it's going to happen. So either you can opt for the national trainer, which is a 1 year, or to become the regional trainer, which is 3 months. If you become PediSTARS member, write to Smita, then we can share all the details with you when it's going to happen. And we have a WhatsApp group, we can add you to that WhatsApp group. So it's not just a PediSTARS activity. We also shared lots of international. We are affiliated with the IPSS and SSH, which is a Society for Simulation in Healthcare, which is a global society for adults and pediatric. So we have lots of programs collaboratively happening, and we can share all these programs. Quite a few are free like this, how we are conducting this monthly program that are happening globally. So we can provide all the inputs and in the WhatsApp group, so you can avail those training programs. And you learn a lot through that. It's not just a faculty development.
Excuse me, madam. Good afternoon, madam. I am
Manjula.
Manjula from Pondicherry.
Hi, Manjula.
Just last week we had one training through INC and NRSC, the GSTU.
Yes.
Gurugramna University, GTU University. So SGTU University, ma'am. So what is the difference between that training and your training? As you say, it is like 3 months as a regional and 1 year for national trainer. But what they said there, like 1 week we have undergone training last week. You can be a trainer for regional, and for the national trainer, like another 6 days training is required.
Correct. To be honest, Manju, you have to answer that question to me. Our first year, a couple of years, we did the same. We did simulation training for 2 days of conference and then 2 days of training. And then we say, okay, certified. And most of them just put that frame in their office and sat pretty. Only a fraction embraced the simulation and started doing it because many people did not feel confident to do the simulation. It's not just doing a simulation, it's a debriefing, which is very important, psychological safety. That's why we created this mentorship. I think Levi's can add to it. Levi's, would you like to say what
Yes,
is the
ma'am. Actually, I thought I will add to your response because as somebody who has undergone the level 3 training of PediSTARS, and I know a few faculty from our college. I'm from AIMS Delhi College of Nursing. They have gone through the INC training also in STD University. So the difference is, Ms. Manju, that the PediSTARS training has an advantage of the mentorship program, which is an intensive program, and they handhold you to do the simulation in your center. Once you come back from the faculty development program, then you will be doing some 6 to 8 scenarios in your college or in your institution. And the PediSTARS faculty will be assigned to you, and they will help you in running the scenarios, give you valuable critical feedback on how to improve the next scenario. So by the time you go through it in another 6-8 months, you gain so much confidence. And at the end of it only, you are certified as level 3. Whereas in the INC, I think it's only the training program for the 1 week, I guess. So that is the main difference, I should say. Yeah, thank you. I hope it's clear.
Okay, but where this is conducted, actually, this training, PediSTARS training?
Yeah, I think Geethanjali can answer that better now, where it's going to be conducted this year.
Yes, we used to conduct it across India in different institutions. This year, we plan to do it virtually or hybrid, so we will let you know when it's happening. Cecilia, would you like to say something?
Like minimum, how many?
Yes. Madam Manju.
Yes, ma'am.
Dr. Manju and Cecilia here. Actually, I second the opinion of Lewis.
Yeah, Cecilia, how are you?
Yeah, I second the opinion of Lewis. Actually, the intensity of the training that we undergo in PediSTARS is entirely different from that of INC. It's like they do a lot of hand holding, and at last the input that they give and the amount of work that we do gives we come little expert. Like, though we cannot say we are experts, the knowledge that we gain and the outcome becomes better. So we have been continuously into it. So till we have completed a year before. Till now, it's like certain type of hand holding is there, and they are always with us to work on. So I think PediSTARS is better.
Thank you, Cecilia. No, we are not here to discuss which is better, any simulation, because our country needs it. So if you have some program which are already doing, now currently doing faculty development, please go for it.
Yeah.
I have personally done my faculty development in 3 different countries over the, I don't know how many years, and I keep doing it and I can't have enough of it. So one faculty development may not be enough. If you do multiple, your whole horizon, it changes.
Yes, sure, ma'am. Ma'am, I like to know how many minimum members you require to conduct this training if we plan for our institution. Is it possible? That's
right. Yeah, you can. Yes, we don't do for the institutions, we do for the whole country. So we'll call for it. So people who are really interested in taking the simulation to the next level, then we select them. Because we do not, the PediSTARS faculty do not get paid for it. We do it as a voluntary. Our whole purpose is to empower the simulation educators or educators to embrace the simulation. So if you want to do exclusively for your institution, do write a PediSTARS and we can consider it, but it has to go through our whole board of directors, and we need to have a separate meetings or the program for it. So write to us to pedistars@gmail.com with your requirement, and we can look into it, or we can advise who else can be providing that. So if you're interested, please do write to us, and we can have a more personal chat about it.
Yes, madam.
So when we trained, for example, Levi's, there were people from across India and also Sri Lanka who came and got trained, people who are actually dedicated to become the enthusiasts to become the simulation trainers. We never did it for us, though we did it the aims, the people came from all over the India, though we did it in the PGI, and the same for CMC Vellore. The faculty and the delegates came from across the India.
Okay, ma'am. Thank you so much.
So, write to us, PediSTARS.com, we'll be able to, and we can take it later how to help you.
Yes, ma'am. Yes, yes.
Any other questions?
Sujata,
Hi, Geethanjali.
Should
Sujata
we
here.
Sujata.
Sorry,
Hi,
I've been in and out of the meeting, but I've been hearing to all the discussions, most of the part of it. So well done, Smita, and thanks, Ella. So just have a couple of questions, I think, for me, which I thought I'll just address it now. So one of the things that was asked is, should we make the nursing simulation training hours mandatory? So I think that's going to be a challenge, especially in a private setup where I am working. I'm sure in the institutions, it can be much more regimented. So what we had was during the COVID crisis, let alone kind of the regular shifts, our nurses had to work 12 hours in their PPE. It was quite strenuous. And we had to protect the nurses as well to make sure they're not coming in between. So during those challenges, we found that, we just asked them to make a focused, simulation training. So it is more like result oriented. Say, for example, so we call that nano or micro simulation. So it's very targeted. So we timed them to set up things for intubation. We timed them for getting the central line care. They had to just demonstrate how to do the central line care. So things like that. So we did a very focused ones during that time. So it is not impossible to actually facilitate the training. Learning should go on irrespective of whether you have time or not. So the next thing is probably, allowing the nurses. So we did a lot of video recordings of various procedures and we shared that with all the nurses. So there are other ways of learning as well. And so something to bear in mind when we have time crisis. The second thing which I wanted to just, highlight is about the FDP. It's a good idea to actually make sure that you go through the training there and then go back and definitely complete the level 3. It is quite important that you go through that. It is not enough to just attend the 2 days workshop hands-on. It's important to make sure that you carry the simulation training, not just at the workshop level and the knowledge level, but to actually make a system change in the place of work. That's when the real buy-in happens in your workplace. So I would seriously recommend everybody to consider that one. And as what Geethanjali said, at the moment, because of the crisis that we are having, we will, please look out at our websites and email us. We'll keep in mind and make sure that, whoever is interested is informed about the FDP whenever it happens. Thank you. And good job, everybody. Thanks all for participating in such huge numbers. Well done, Smita, once again.
Keep the momentum going. I think we should end the meeting because many of us have to get back to work. And thank you very much. Jamuna, would you like to say something? So I know you have lots of questions. So we can continue to chat on the WhatsApp, those who are members of PediSTARS, or if you would like to join, let Smita know. And we will continue to do this every month, if possible, or alternate months. And you're all welcome to join, and let your colleagues know as well if they would like to join. And all the best. You have the email which is gone from Smita and us regarding invitation for Zoom. If you have any questions related to simulation, you can just email us back and we are just a few seconds away to answer your queries to help you.
Thank you, everyone.
Thank you so much, Smita. Thank you all for attending. Ruchi, thank you so much for being there and helping us with technical aspects. And Ruchi, if you can unmute, sorry, if you can show your video.
Thank you, Dr. Geethanjali.
Thank you, ma'am.
Thank you so much, Ruchi. She's been the kind of backbone in making this happen. And Ruchi is a senior educator at the Lateral, and they've been helping us since years and years. And Ruchi especially intensely since the last 1 year in conducting emergency and neonatal simulation across the country in virtual simulation. Thank you so much, Ruchi. Appreciate your dedication despite being the weekend. All right. Bye-bye. Take care, all of you. Have a great weekend. Bye-bye. Bye-bye.
I will end the call now.
Sure. Thank you.